Because it's like medical. It's like you're gonna be sitting
start
it's like
fixing Kim's
and that's what scares me. So I'm like
Tell stories.
inside.
I love this story.
And then I think we're gonna sew that together.
Is the materials for this stuff, is it online, or do you want me to
Okay, I think we're ready to go. Thank you all for coming. This talk is part of an NSF-sponsored program for recruiting PhD students into engineering psychology programs. This particular one is on, or the general area is on smart homes, specifically automating homes in order to support aging in place. And so we're interested in recruiting good PhD students to work in those areas. And also part of the program is to bring in distinguished visitors so we can hear about the research that's going on in the area. So today we have Dr. Wendy Thornton, an associate professor in psychology at Simon Fraser University, and also associate member of the Gen Technology department there, and does work in general in cognitive aging, and she's going to talk about that today. Thank you.
Thank you very much. So I've had the pleasure to meet some of you today, and I've had a really nice couple of days here. You've got a very impressive program. I got to tour the smart home, which was extremely interesting, and then it was nice meeting with some of the engineering students and faculty at lunch and getting a better understanding of sort of what your vision for that is and what you're doing, what your goals are. So thank you. It's been really nice. So now I'm going to talk a little bit more about the kind of stuff that we're doing up in the Cognitive Aging Lab at Simon Fraser University. And so we are up at SFU in beautiful Vancouver, which actually is beautiful a good portion of the year. It does rain there a little bit. But, and this, of course, on the bottom here is Simon Fraser University. We're located on the top of a mountain, which has its pros and cons. It's absolutely gorgeous. Great hiking around the mountain. Really hard to get older adults to come up the mountain to be tested, but luckily we have satellite sites around the Lower Mainland, so we're able to do a lot of our testing there. And we do have our cognitive aging lab where we do a lot of our experiments as well. So what I'm going to be talking about today is sort of a general introduction of cognitive aging. I'm sure that many of you have had some of this, but okay, you know what, let me just ask you. How many of you have had some introduction to cognitive aging? Okay, how many of you have, okay, so you know what, I'm just going to pitch this, and you're just, at sort of a level where I hope everybody can, and I'll try not to be too jargony, but please stop me if I start using jargon or go off on a tangent that you don't understand and ask for clarification. I am a lot happier in this setting if it can be interactive. I bore myself otherwise. And you can imagine if I bore myself, what the result will be for you. So don't hesitate if, and I'll be checking periodically for feedback just to make sure that we're all sort of on the same page. But what I'm hoping to convince you of, first of all, by the end of this talk, is that really, George Burns pretty much had it right. By the time we're 80 years old, we have learned basically everything, and we can demonstrate that with a lot of our paper and pencil tests. However, how we apply that knowledge that we've gained over the lifespan, in terms of paper and pencil tests, behavioral measures, outcome measures, etc. That's sort of where the rubber hits the road, and that's where it becomes more difficult. So we're going to talk about predicting functional outcome. Really what we're looking at in my lab is finding better predictors. I've said this several times today, and I apologize for those of you who've heard it twice. But why I find cognitive aging so fascinating to study is because of the heterogeneity that we see. And so that's a point that I'm going to be making throughout this talk, is why is it, and you've seen me do this too, and I'm sorry, but it's just something I do. We start out here, and at 5 years old, we're at a pretty similar place in life, right? 5-year-olds in a kindergarten classroom are really fairly homogeneous. Now, my developmental colleagues hate me when I say this, but they're just going to have to deal with it. They're a pretty homogeneous group. In terms of their language function, there's some variability, but what's interesting to me is what happens when we follow that group of fairly homogeneous 5-year-olds till they're 75. And now we have one who's going to the moon, literally as an astronaut, right? And who has the physical functioning of a 40-year-old and the cognitive functioning of somebody in their late 20s, early 30s. And we have somebody devastated with Alzheimer's disease. It's that variability that we're going to be talking about today. It's a challenge from a research perspective. It's a terrible challenge from a predicting outcome and functional outcomes perspective as well. And so trying to predict where the break occurs, okay, what sets us off on these different trajectories as we get older. Trying to identify risk factors, modifiers as I call them, for both positive outcomes and negative outcomes. We're going to be talking about a lot of those today. What's the best, most reliable predictors that we have, and then finally, talking about everyday cognition, which has been my area of research in the past couple of years, and I'm going to try to convince you, or at least make the case for the fact, that including some of those everyday measures into our predictive equations has additive value over our traditional cognitive tests. And then we're going to talk about some of the challenges in measuring functional outcome. I know that that's what a lot of you guys are right in the throes of right now. It's a critical question. That's why I'm entitled to talk the Holy Grail. I mean, it really is the piece that's missing from all of this. I can stand up here and I can show you slide after slide after slide after slide, showing that there's cognitive deterioration on this and this and this and this and this. But if it doesn't have a meaningful outcome in the life of the older adult, who cares? I mean, you guys, you know, it's really important at the age of 20, 25 that you're very efficient information processors, right? That's your job. You need to come here and you need to study and you need to learn vast amounts of information and you need to regurgitate it, right? You're information processing machines. And you're more than that, but I get it. Okay. But how, does an 82-year-old really need to do that? So does it matter that I can give a 20-year-old and an 82-year-old the same test and the 82-year-old performs worse? What does that mean? What am I trying to predict? What is the goal here? So we're going to talk a little bit about how we've tried to wrap our head around measuring some functional outcomes with varying degrees of success and talk about new directions. So that's where we're hoping to go today. This is the slide, the obligatory slide that will show you what many classes have shown you before, which is that there's a lot more older people out there now, and when you guys are old, there's going to be even a lot more older people out there now. Why are people suddenly, why is there a burgeoning of gerontology programs around North America? Because people are recognizing that there's going to be a lot of 85-year-old people in about 30 years. What's the risk of dementias, like Alzheimer's disease? Well, 11% lifetime risk over the age of 65 for men, 19% for women. 30% of North Americans age 85 and older are diagnosed with dementia. Some estimates are even higher than that. That's a lot of older people. That's a lot of older people that are going to need a lot of resources, right? And so people are getting more and more interested in these questions. How to predict who ages well? Can we design interventions to help us age better? Can we reduce the economic costs that are going to be incurred from having all of these older people with serious functional difficulties in the near future? Today's lecture, though, I need to tell you, to please talk. The focus of my research is on non-demented elderly, so I'm not really going to be talking about Alzheimer's disease or other dementing illnesses. I'm going to be what we do in my lab is we try to investigate aging by looking at healthy older adults and trying to predict within that group of community-dwelling healthy older adults risk factors for increased cognitive decline even within that group, okay? So it's not just that we're on a bidirectional path, folks. It's not that we either age well or we get Alzheimer's disease, right? And that, I think that distinction is sometimes lost. It's that we can get Alzheimer's disease and there's a whole big, vast world on the other side of that between people who have significant functional impairments without dementia and people who just do amazingly well, right? We call them, we call that sometimes optimal aging. So aging has consequences, all right? I mean, everybody knows that. Our basal metabolic rate goes down. We were kind of joking at lunch about, how fun it was when we were 20, we could eat whatever we wanted. And then, you're 46 and your basal metabolic rate has declined a little bit, and you got to watch that a little bit more. Maximum heart rate goes down. Resting cardiac output goes down. Muscle strength goes down. We can lift all the weights that you want to lift. Your muscle strength is still going to go down. You can improve that. I mean, you can make it go down less, but we lose strength as we get older. Bone mineral mass declines. Maximal cardiac output declines. Vital capacity declines. Work capacity declines. But the good news is other stuff goes up, okay? Like heart rate, diastolic blood pressure, body weight, heart volume, okay? So it's not all downhill, okay? There's some upswings in it. We have physical changes as we get older. We're all going to experience them. You will all develop a wrinkle. Most of you will all get gray hair. So should we really be all that surprised that there are brain changes as well? And in fact, by some estimations, the brain changes that we see are basically commensurate with the physical, in degree to the physical changes that we see. It really shouldn't surprise us. The brain does shrink. So we see general atrophy across the cortex with age. And some of the largest changes that we see are in prefrontal cortex and other areas that I'm not going to focus on so much today. Caudate cerebellum, for example, and of course hippocampus. And what's the hippocampus important for? Okay, what's the prefrontal cortex important for?
Decision making.
Executive function, decision making, problem solving, absolutely. But it's not just, we see a lot of variability even just in the brain with older adults. For example, the occipital areas show the smallest effects of age with the correlation of about negative 0.19. We also have structural changes to white matter. I made the case this morning in talking about executive functioning that really the job of the prefrontal cortex is to coordinate with other brain areas. So you can have a fully intact cortex, but if you take out the wiring, it's not going to do a very good job, right? So if this job is basically the job of this area, the prefrontal cortex, the conductor, the general, whatever you want to call it in the brain, whose job is planning and problem solving and prioritization and all of these higher order executive functions, if we take down its ability to communicate with the rest of the brain, we effectively take it down, right? And so we examine the white matter that underlies the cortex in the frontal lobes, the deep white matter. And with aging, we have an increase in white matter hyperintensities, which are basically little white spots that show that there's been decomposition in those areas that show up on an MRI scan. That's why they're called white matter hyperintensities, because water is hyper intense on the scans, right? And so we see these little spots, and we know that they're correlated with greater cognitive change, decline rather, with aging. The more little white matter hyperintensities you have, the worse your cognitive performance on certain types of tasks. And we know that things like smoking, high blood pressure, hypertension, diabetes, all lead to an increase in these white matter hyperintensities. So they seem to be a marker for the integrity of our vascular system. Okay. So we also see structural changes, not only cortically, but also subcortically as well, okay? Does cognition decline with age? Well, absolutely. I like this slide. It's taken from WASTE data for any clinical students in here. But this is, probably some of the most powerful tools that we as clinical psychologists have in our armamentarium in terms of very good, reliable tasks that are extremely well normed. And what it tells us time and time again is that, several things to notice here. First of all, if I were to just collapse across all of these four aspects of intelligence, verbal comprehension, perceptual organization, processing speed, and working memory, I would have a curve that looked sort of like this, right? But that wouldn't really tell us the whole story, would it? We'd miss the fact that there are some things that actually get better into midlife, hold pretty steady, and show a very subtle decline. So keep this in mind, because when I talk about everyday problem solving, it really comes out of some of these findings right here. verbal comprehension, verbal knowledge, our knowledge about the world, our information, remains intact and is pretty well preserved across the lifespan on average. So that's back to the George Burns thing, right? You've pretty much learned, you pretty much know everything. But there's other things that show precipitous decline starting as early as the 20s. And that would be processing speed. That's what I told you before. You guys are just geared to be information processors here. You're quick, you're fast, you're very good at learning information and spitting it out. It's what you're supposed to do now. That's your task in life. Learn stuff, right? But for an 85-year-old, it just may not be as relevant or important. So we see precipitous declines in processing speed. The question is, what are the functional consequences of that? We see fairly precipitous declines in perceptual organization and, of course, in working memory. And that's our ability to sort of multitask, spatial orientation, spatial organization, problem solving. And so a lot of this can be roughly broken down into what happens when we hit a fast, novel meaning new, a novel, new, fast problem, how our brain responds to that, versus when it's information that we have experience with and we have knowledge with. And so we do seem to see some separation. Is everybody with me here? Okay. And so again, an important point here that I've made, repeatedly, but in physical functioning and cognitive functioning, aging is not uniform. And that's why taking cognition into account as part of the equation is so important. So, John Glenn was an astronaut at 77, and, we see physical changes with aging, but again, there's tremendous variation there. And because aging is not uniform, what this tells us is that we can't necessarily ascribe the age-related changes that we see to an aging process. What do I mean by that? There's nothing magical about chronological age, right? 50 is not 50 is not 50 is not 50 in a room full of 50-year-olds. They'll have tremendous variability. So what other factors do we need to look at, if it's not chronological age, if it's not just years on this planet, that account for the variability that we see? We know that there are many risk factors for more precipitous decline on our cognitive measures, and I've talked about some of these. Vascular health, you are as old as your arteries, is an old adage that still holds pretty well today. So the presence of hypertension, particularly in midlife, is a significant risk factor for more precipitous cognitive decline. Diabetes is a precipitous risk factor for more precipitous cognitive decline. Insulin resistance now is emerging, sort of the pre-diabetic state, as a risk factor for more precipitous cognitive decline and development of Alzheimer's disease later on. Some of the work that we've done in chronic kidney disease, the reason we look at chronic kidney disease is because you get chronic kidney disease pretty much from hypertension and diabetes. And what happens in persons with chronic kidney disease is that the net result of hypertension and diabetes together takes out the very fragile cells in your kidneys, and that's kind of a marker for what's happening in the brain. So as the kidneys start to fail, oftentimes we also see that the brain's taking little hits at the same time. So we've seen accelerated aging in this population as well. There are tremendous genetic contributions, in terms of how long we live and how well we age. Certainly, I'm sure some of you are familiar with some of the ApoE4 data, COMP data. There are a lot of genes that have been identified that seem to have an important role not only in how we metabolize lipids, but in terms of risk factors for developing amyloid plaques, for example, in Alzheimer's disease. And of course, things like gender, education, and personality. All of these things as well contribute to how well and how much variability there is in aging. Gender is a really tricky one. Women are more prone to get Alzheimer's disease. It's there's lots of potential explanations for that, many of which are hormonal. I know they just released a study, I just heard about it yesterday. I don't even know if you heard about this new data about hormone replacement therapy that doesn't look very good. I thought we were done with that one, but now it's getting really complicated again. I'm not even going to talk about it. I just heard the press release. But if you're interested in that, keep your ears open. There's data on the horizon that, that is interesting. Education. People who have higher levels of education appear to be at a slightly lower risk of developing dementia and of preserving their cognitive functions. But again, that data is not as clear as many of us would like it to believe to be. And I would say that we're not entirely clear on whether it's, we know that people with very low levels of education, under 6 years of education, or 6 years and under, for example, are at much higher risk for developing dementias. What's less clear is how protective it is at the other end. And again, people who are educated and not educated are different from the get-go, right? I mean, people who are lucky enough to be able to go to university and get a university degree and graduate degrees, my gosh, you've been blessed from birth, probably with really good, smart parents, and you had good prenatal health, and you went to good schools, and you know what I'm saying? So you're very different from people who don't have that. So just attributing it to education is a bit naive. Personality factors. Certainly SHI's data, has shown us that, there are personality factors as well, being, more flexible in your thinking and in your approach to life may also be associated with better cognitive aging. This is just some data from our lab where we look at effects of chronic illness. I told you that the presence of chronic kidney disease led to accelerated cognitive aging. Now this is not longitudinal data, this is cross-sectional data, so I do use that as a caveat when I use the word accelerated. They let us get away with that in the journal, so I'm going to get away with it here. But the point being that, this is a group of individuals aged 30 to 90, and you can see, and again, these are people living in the community. They're not on dialysis. They're not sick people. They're working full-time jobs, right? They have hypertension and diabetes, and their kidneys are starting to cause some problems, so they're on dietary restrictions and medications. And lo and behold, what we see on our verbal learning tests is that we see what appears to be an accelerated trajectory as they get older in terms of, compared to age, education, and gender-matched controls, the impairments on memory tests is worse in the people that have the chronic illness. So that's one of the modifiers that we've been looking at in our laboratory. But again, the important thing to keep in mind is that the losses that we see are not uniform. So that even within a cohort of individuals like the one that I just showed you, and this is the healthy aging control group here, we see negative correlations with memory and executive function and age. But look at what we have for vocabulary abilities. We have positive associations with semantic knowledge. So age loss, so losses are not uniform, and it's important to remember that there are also gains, right? Gains in semantic knowledge. And so this has led some people to criticize our approach to cognitive aging, the traditional approach to cognitive aging. And they've said, look, our cognitive measures don't really capture cognitive aging. We can throw, I can throw any test at a group of 70 and 80-year-olds and compare them to a group of 20-year-olds. And if I make sure that they're speeded tests, that they load heavily on executive functioning, I promise you, and that they load heavily on memory, recall, I promise you the older adults on average will look worse than the 20-year-olds. But at a certain point, you just have to say to yourself, does that really capture what the older adult is capable of doing? I mean, I've tested older adults in my laboratory where you'd be amazed a person can tie their shoes. The fact of the matter is they do really, really well out there because their environment doesn't pull those things. They're not asked to do really, really fast problem solving of novel tasks. Very often, who cares? They're 85 years old, right? And so how well do our measures predict real-world challenges that these people face? What skills are necessary to effectively navigate life at 85? I mean, how many of us can answer that question? It's a really important question that I don't see really a lot of good information on it. What basic fundamental skills do you need at 85 to be able to effectively navigate your environment and live independently? I don't know. Not hurt yourself, I guess. But I mean, seriously. So what are we trying to predict? And that brings into account the very important question that Maureen has done a lot of excellent work in about ecological validity. So the question that's always staring us in the face, people who assess cognition, is are our tests ecologically valid? How well do they translate into real-world functioning? Now, IQ tests are wonderful at predicting academic achievement. They were designed to predict academic achievement, and they do a bang-up job of predicting academic achievement. By the time you're 40, you pretty much probably finished your academic achievement. So what's the utility of an IQ test after that? We've got to kind of scratch our heads. Do they predict everyday function? And then the important point about how do the tests that we give in the laboratory capture these age-related gains? What about this whole concept of wisdom? Is there anything to wisdom? Is there anything to experience? How in the world do we quantify wisdom and experience in the laboratory? Paul Volta spent his career trying to do this. He's done brilliant studies. But still, he acknowledged how elusive this construct was. Very difficult to capture these things. But what this sort of movement has tried to do is to operationalize these sorry, I got ahead of myself. So what we've tried to do here is develop tasks that allow us to access everyday cognition. And everyday cognition, I've put up the definition here that I'll just read to you: the application of mental abilities and domain-specific knowledge to solving problems that are integrated within instrumental domains of everyday functioning. So this is kind of a key definition of everyday cognition. What we're trying to do is have tasks that actually map onto and predict everyday functioning. And within the domain of everyday cognition is everyday problem solving, and this is where I've been doing my work. And how do we define everyday problem solving? A problem is identified that can be expected to commonly occur within the lives of individuals. And the problem solver is required to generate a solution or solutions that can be expected to be positively associated with the desirable resolution of the problem. So this is a definition that we came up in our meta-analysis, and we're still using it today. So what is an everyday problem-solving task? There are two types I'm going to talk about here. The first tests are ill-structured everyday problem-solving tasks. And here you simply present the person with an open-ended question. For example, you have lost your blood pressure medication. What do you do? Come up with as many safe and effective solutions as you can think of. There's no time limit. Take your time, give me solutions. So give me some solutions to this. What would you do? You've lost your blood pressure medication. What do you do?
Call your pharmacy.
Call your pharmacy? Okay, what else? Give me more.
Retrace your steps.
Retrace your steps. Okay, anything else? Those are both two safe and effective solutions. So far you're at 2. You're a big group. You should be doing better than that, guys. Okay, anything else? What do you do?
Call your doctor, call your family.
Call your doctor, call your family. I think, okay, I'll give you one for each of those. One of the things that we have to do is we have to make sure that they're distinct solutions. So you can't just say, call your brother, call your sister, call your mother, call your dad, call your aunt, no, that doesn't count. So anyway, that's where it gets tricky in here, is trying to score this. So we come up with as many conceptually safe and effective solutions as we can. Breaking the pills in half to make them last longer or whatever would be not a safe or effective solution. So they won't get a point for that. And there's many different ways that we can score it. We can just look at overall fluency. We can look at fluency plus quality, which is the way that most people do it. Or we can come up with a quality score as well, where you ask the person to decide on the best solution that they came up with, and then you assign a quality rating to that. There are also well-structured everyday problem-solving tasks, and these come out of Marciska and Sherry Willis and Jason Allaire's labs. And this would be when a drug expires, you should... The person is given a list of items and they have to select. So what's the best answer here? You should call your doctor. Exactly. So here we have a well-structured task because there are a finite number of solutions that they have to identify and really recognize, right? And then these move into even more sort of realistic type tasks. Your doctor told you to eat a diet low in sodium. Which of these 2 brands of peanut butter should you choose? And you hand the person the 2 nutrition labels. So what would you attend to on those nutrition labels to make this choice?
Sodium.
What else? Sorry?
Serving size.
Their serving size, thank you. That's what people miss. You see, that's the tricky little part of this. But absolutely. And of course, this is a task where, they've worked really hard to approximate. I mean, imagine in the older adult walking into Safeway and being faced with this array, and he's told to, have a diet low in sodium. I mean, how hard can we make it for these folks? Not only do they have to read the nutrition label, but they better have a good pair of these, because that stuff is tiny, okay? You know what I'm saying? So we're very good at making the environment extremely complex and difficult for older adults to navigate. So these are some of the everyday problem-solving tasks that we would use. So there are two models of everyday problem-solving in adulthood. The construct of everyday problem-solving has been around for a bit. There's been a lot of work really in the last decade on it. But initially, everyday problem-solving was argued, or the argument was made, that cognition should be bolstered on these tasks by accumulated knowledge, structures, and experience. That is, what we're doing is we're giving older adults exactly the kind of tasks that they've had tons of experience with. They're probably, your parents have probably read a few more nutrition labels than you guys have, I would guess, right? They probably taught you how to read nutrition labels. Your parents have probably had, or your grandparents have probably had a lot more experience taking medications and running out of medications than you guys have. So they may be able to use that accumulated knowledge and wisdom to actually perform better on those tasks than you would. Right? Does that make sense? That's the argument that was made. The counter-argument to that was, sorry folks, even though these are everyday tasks, what we're asking older adults to do and apply when we give them any cognitive task is that task is compiled from primary mental abilities that decline with age. You need to know how to basically scan to find the right information. You need to have adequate memory. It doesn't matter if you've done it 10 times in the past. If you don't recall how effectively you solved it in the past, it's not going to work for you. And you need to have adequate raw problem-solving skills to be able to apply it. And you need to have enough flexibility in thinking to be able to generate multiple solutions to a problem in case your first one doesn't work. Okay? So this predicts that we should see declines in everyday problem solving in older adults, just like we do with everything else. So what do you guys think? Which camp wins? Do we see better everyday problem solving in older adults, or than younger adults, or do we see worse everyday problem solving in older adults than younger adults? What do you think? Somebody's got to have an opinion. That's a good, safe answer, yes. But yes and no. How's that? Well, okay, I'll show you. The best news on this for many of us in the room is that there's also good evidence that this ability may actually peak in midlife. And the theory for this is that at midlife, we have the perfect sort of, combination of experience and wisdom. And we still have our cognitive faculties intact. Yay. So we're really the best everyday problem solvers. So who believes that? Okay. Let's see what happens. So here's some data from a study that we just completed that's coming out in Journal of Gerontology. What we did for this study to try to resolve this question was it's been argued that time and time again the data seems to suggest that older adults do worse on everyday problem-solving tasks. Even though we'd like to think that they do better, guess what? They do worse than the younger adults. But then the argument was made, yeah, but that's because you don't have the right task. Okay? You haven't designed a task that is actually meaningful and salient to older adults, and you missed the key part of this, which is it has to be something that they have experience with and that they care about. And if you can design that task, older adults will do better than younger adults. So we said, okay, you're on. All right? We're going to take older and younger adults, and we are going to have them rate all the vignettes that have been used in past literature. And we're going to have them say, is this a problem that older adults would face or a problem that younger adults would face? Is this a problem because older adults should do better on older adult problems, right? Right, in theory? And then, because there's a very influential theory out there, socio-emotional selectivity theory. Laura Carstensen and her crew have suggested that older adults, that interpersonal and social concerns are much more salient and relevant to older adults than our practical concerns. So what we did was we had them, older adults and younger adults, rate these problems for how practical they were versus how socially relevant they were, how relevant they would be to them, how relevant they would be to a typical older or younger adult, and whether it was a problem that an older adult would typically face or a younger adult would typically face. Then we took those ratings and we constructed 16 problems in 4 groups. Older adult interpersonal, older adult practical, younger adult interpersonal, younger adult practical. And we ran it in a new group of participants. And guess what we found? Well, no matter what we threw at them, overall, older adults did not generate as many safe and effective solutions as did younger or middle-aged adults. And in fact, middle-aged adults did best. They generated more solutions. But what about on the interpersonal concerns? I mean, older adults are supposed to find interpersonal social predicaments much more salient and do better. Actually, they perform significantly worse than both younger and middle-aged adults when the problem content was interpersonal. And they performed, where's my mouse? There we go. Significantly worse than younger and older adults when the problem was specifically designed and rated by them to be an older adult problem. So I've done my best job that I know how to do to find a problem that older adults, as an everyday problem that they will do better on. And we were not able to do it. Now for the good news. For those of us in this room that are middle-aged, you will love this. Middle-aged adults did better overall than younger or older adults. And that effect was most striking when problems were practical. So the other thing that I would want to draw your attention to here, though, is the age of our samples. And I think sometimes this is where some studies run into a little bit of trouble and where there appears to be differences in study outcomes when in fact there's none. In our meta-analysis that we did in 2005, we reported that there was a clear decline in everyday problem solving in older adulthood that appeared to be pronounced at about age 70. Okay? Now, what is old? Give me a cutoff for old. But you know, I mean, many studies would say 65 to 74, young old, 75 to 84, old, 85 to 100, oldest old, and then centenarians, right? But you see aging studies published out there that go down as low as 60, sometimes 55, right? Older subjects are tough to get, man. You get really practical when you're in the laboratory. It's like, okay, you look old to me. Come on in. The problem is, you know, look at the average age of my middle-aged sample here. It's almost 60. Okay. And look at the average age of my older sample here, which is 71. So just a cautionary tone that if you're doing an aging study and you're looking at everyday cognition, you know, the literature is telling us that we really shouldn't expect to see age-related declines that are reliable until after age 70. So if you're going to allow everybody over 60 and call them old into your aging studies, you might be shooting yourself in the foot and washing out a lot of your aging effects, okay? My lab, because the older I get, the older my middle-aged subjects get, I can tell you that. But I mean, you know, we take 40 to 59 as middle age. Sometimes 50 to 64 I've even gone, because I think that the data really does, you know, my data is telling me that I really should not be expecting to see age effects until over the age of 65. All right, so again, I'm just showing you, so we appear to have reliable effects even on everyday problem-solving tests. But to put these in context, and these are the results from our meta-analysis, at least on the bottom there. You know, the largest effects that we see, I mean, this is summarizing results of other meta-analyses here in the top part, right, are around a standard deviation difference between younger and older adults. And these are on measures of recall memory. In comparison, we see on average a half a standard deviation difference favoring older adults in vocabulary and roughly a half a standard deviation difference favoring younger adults in everyday problem solving. So while we do see a reliable decline in everyday problem solving measures, the magnitude is about half of what we see in memory recall. Okay? So, what is everyday problem solving? It is a form of compiled cognition. This is my argument. I don't think it's necessarily a special or unique form of cognition, but it's clearly based upon some of these primary mental abilities. Well-structured tasks appear to be most heavily correlated with fluid and crystallized intelligence, and the ill-structured tasks seem to show highest correlations with memory, executive functioning, and word knowledge and fluency. There seem to be two distinctive predictors, though, of performance in everyday problem-solving tasks, and this is fluid mechanic abilities and verbal knowledge. They tend to be unique predictors. And there's also a little bit of evidence, well, some stuff that we're working up right now, that underlying basic mental abilities may differ according to age. That is, executive functioning may predict everyday problem-solving in younger adults, whereas semantic knowledge may predict everyday problem-solving in older adults. So is there anything unique to everyday problem solving? Does it give us anything over and above our entire armamentarium of other, traditional neuropsych tasks that we've had forever? Sorry, I forgot I put the slide in here. This is also from another study where we looked at, again, just showing you, getting at the question of sort of redundancy. Do these everyday problem solving measures add anything, or are they just completely redundant with our other neurocognitive tasks? And this is a study where we looked at whether or not memory and executive abilities and vocabulary abilities mediated the pathway between age and everyday problem solving. And what we showed was partial mediation with memory and executive functioning. Do you know what I mean by partial mediation? Okay, what we're saying here is that this correlation, this association between age and everyday problem solving, if we add memory and executive functioning into that model, in mediation modeling, that correlation drops. So we're accounting for a significant percentage of the variance in that relationship. But this is still significant. So it partially accounts for the relationship between age and everyday problem solving, but not fully. So there's a lot still left over by age in of itself for predicting everyday problem solving that is not accounted for by other cognitive abilities. Follow me on that? Okay. I'm trying to think if I can think of another way to say it. But, so memory and executive abilities are part of the picture, but they're not the full picture. There's still something unique to everyday problem solving that our other neuropsych measures are not capturing. So if there's some portion of that pie that's unique to everyday problem solving, what is it? And is it important? Should we be adding it to our batteries? Well, if everyday problem solving is closer to the real world, it should be strongly related to real world outcome. That's what ecological validity is all about. So now it's time to say, so we've made all these pretty tests, and they look like real world tests. They have good face validity, okay? They look more like a real world test than our silly little, matrix tests. But do they actually predict better or not? And there's been amazingly little work in this area. We seem to be very comfortable with just taking something at as face valid and saying, sure, that's more ecologically valid. It looks more like the peanut butter test. So we are accumulating evidence slowly that everyday problem-solving measures are better than traditional neuropsychological measures for predicting daily functioning ratings. Some of that work has come out of our laboratory with patients with schizophrenia spectrum disorder, where actually it did a better job of predicting nurses' rating scales than IQ and other neuropsych measures. It did a better job of predicting self-reported daily functioning in a group of community-dwelling elderly, and it seems to do a better job than our traditional neuropsych tests at measuring quality of life. So I am ready to conclude that there is evidence for added value of everyday problem solving. It has unique variance, and it seems to do a better job of predicting functioning than traditional cognitive measures. But now this brings us to our second challenge, okay? Which is, so we're better at predicting, self-ratings and nurses' ratings, but do we have outcome measures? The first question was, do we have predictors, okay, that are useful? And now, do we have outcome measures that adequately capture older adults' ranges of function? Now, the most commonly used outcome measure in this literature, I'm sad to say, are the Lawton and Brody independent activities of daily living skills. It's a wonderful test for demented populations, but for healthy community-dwelling elderly, there's no way. The ceiling on this is far too low. For example, let's say that we want to rate the transportation ability of this woman on the slide, right? How effective is she at using transportation to get around? Well, our Lawton and Brody scale would give her a 1, right? So she'd basically rate, because you can only get a 1, right? I mean, so you're either a 1 or a 0. So she would do about as well as somebody who travels on public transportation when accompanied by another. I mean, is this capturing what this woman is capable of doing in terms of transportation? Probably not. We need to have something a little bit better. And so, this is always going to be the challenge here, is that most of the reliable psychometric measures that we have were developed for quite ill populations, and the ceilings are simply too low. I mean, we've used IADLs in all of the studies that I've told you about, and I can tell you that my mean ADLs are 8. It only goes to 8. That is not a useful scale, okay? So we're just trying to wrap our heads around this question of measuring outcome, and that's why it's so fun to be down here and see what you guys are doing, because you're really sort of embroiled in this right now at the Smart Home, and really trying to quantify these things with your MCI populations and your dementia populations, and trying to capture this elusive goal of figuring out not only how behavior, in as close an approximation as you can get to the real world environment, is associated with our beloved little behavior or paper and pencil measures here, but also trying to sort of see if perhaps they could be better. So, a study that we recently did, and Shannon Gill, this was her dissertation that just came out a few months ago, we tried to wrap our head around, I told you that we're interested in kidney disease, and so that led us to renal transplant, around a problem that we could sink our teeth into, which was medication adherence. So why is medication adherence important? Well, non-adherent kidney recipients are up to 7 times more likely to lose their graft, meaning lose the new kidney. Okay, why is it bad to lose your new kidney? Because you'll die unless they can find another kidney for you, and finding one kidney is hard enough. Yet typical non-adherence rates are as low as 50%. The medications you have to take after transplant are difficult. They have side effects. People don't like to take them. Eventually you start feeling better, and people just seem to stop taking them after a while. So trying to get at this question of what predicts medication adherence in this group. We already know that they're prone to a few sort of subtle cognitive problems. So what does cognition add to this equation? And again, I mean, we first of all have to really, really carefully define our outcome here, our dependent measure. What is medication adherence? Is it simply, and you have to look very carefully at the definitions here. It's the accurate use of medication, the accurate use. Taking the appropriate number of doses at the right time in the amount prescribed. Okay? You see how many variables there are there? Doing it accurately, taking the appropriate number of doses at the right time in the amount prescribed. What outcome measure is going to give us that? What can we look at? We looked at technology for that. Is that going to tell us? Challenges. Many of these patients, including many elderly patients, are on multiple medications. They have cognitive limitations, and they have personality factors that can affect how they approach their whole illness and taking medication in general. So these are some of the most common ways that are used to measure medication adherence. Electronic monitoring was really, really the cat's meow for a while. Everybody loved their MEMS caps. I don't even remember what MEMS stands for anymore. Medication Electronic Monitoring System, I think. Cool little device. Basically what it does is it's a pill bottle cap, right? You stick it on a pill bottle, it records when and how many times the medication is opened. So in our definition of medication adherence, how many of those criteria are met? So MEMS cap will tell us when the bottle is open. Won't tell you whether they took it the amount prescribed. Won't tell you if they took it at all, will it? It'll simply tell you the bottle was opened. The problem with the big problem with the MEMS caps is, they're incredibly expensive. At one point they were $1,000 per cap. I hope they've come down now. And that was for one patient, one medication, one use. Once you put the medications in the bottle, that cap can never be used again because it's contaminated. Okay? This makes for a fairly expensive medication adherence study. Okay? We did not opt to use MEMS caps. And in fact, the biggest problem with this application of technology is there's no way to ensure ingestion. So how do we ensure ingestion? Self-report is most commonly used, but of course, anytime you have a self-report measure, this is subject to response bias. Recency effects, we tend to remember the most recent, 2 weeks of behavior much better than the weeks prior to that. But it does allow you to take in more information. You can ask, not only did you have trouble remembering to take your medication at all, but how often did you take it late? Did you ever cut your medication in half because you were running out? Did you ever double dose out of medication because you realized that you forgot to take it the night before? You can get a lot more qualitative information. Pharmacy records, people oftentimes use pharmacy records to measure adherence, but these tend to overestimate compliance. Almost everybody on a prescription plan gets their medications filled. Doesn't mean that they took them. Pill counts, again, tend to overestimate adherence. That's bringing your pills actually in and having the nurse count them for you. You can bring in as many pills as you want. It doesn't mean that you're taking them. The only way to ensure ingestion is serum concentrations, where you actually measure the medication in the bloodstream. That tells you that it was taken. But the problem with that is that really only tells you the medication that was taken in the 24 to 48 to 72 hours prior to the lab test. So there's a white coat compliance problem where people tend to get really compliant with their medications right before the lab tests, right? So what we did for this study was we tried to combine outcome measures here with the hopes of coming up with a composite measure. So we looked at the self-report, we had the transplant effect questionnaire, we had pharmacy records, and we had serum concentrations. And it was really a learning experience for us. Serum concentrations only classified 15.5% as non-adherent. Virtually everybody had the medication in their bloodstreams. Prescription refill, 26% of our participants were over 100% compliant. That didn't offer us much. Everybody gets their prescriptions filled. Self-report, 20% reported problems with adherence. But they did give us enough variability in their responding here that we were able to use that as an outcome measure. What we found here was that what predicted medication adherence reliably in this sample, as opposed to age and education, older adults were okay. Wait a second here. Older adults were actually more adherent, and higher education was associated with better adherence. But CESD, having higher ratings of depression, were associated with worse adherence and better performance on the everyday problem-solving test was associated with better adherence. The neuropsych composite measure, memory and executive functioning, basically gave us nothing. So more evidence that at least in terms of predicting medication adherence, everyday problem solving was a better predictor. So, ongoing work in our lab. We are continuing to look at predictors of everyday problem solving. Now we're just starting a blood pressure study where we're looking at in-home blood pressure monitoring and cognition, where we're trying to train people in their homes to monitor their blood pressure and see if that's a better predictor of cognitive performance than the blood pressure that we can get in the laboratory. And this is a follow-up to a study that's under review right now, where we basically looked at a very healthy group of community-dwelling women. We had previously shown in another study that having high blood pressure late in life, having a diagnosis of hypertension, was related to worse everyday problem solving. So then we looked at a broader range of women with a broader range of normal blood pressure and low blood pressure, and we found in this study that actually having low blood pressure was also predictive of worse everyday problem solving and traditional problem solving. So what we're presuming is going to operate here in our broader study, in our larger study, is that we're going to see sort of, a U-shaped relationship. We're having blood pressure outside the range, either too low or too high, predicts worse cognitive performance. We're looking at the relationship between self-rated physical functioning and mental health in predicting everyday problem-solving performance, and it seems like lower self-rated physical functioning at this point is associated with worse problem-solving. So in summary, what we await are better tools for measuring outcome. So we're working on identifying the predictors and figuring out, what to put into the equation to predict functioning, but we're still trying to figure out the best tools for actually measuring how older adults are doing in their daily lives. So older adults do experience cognitive changes that have implications for their daily functioning. We know that. Everyday problem solving, I'm arguing, is emerging as with considerable promise in predicting relevant real-world outcomes, but there exists a great need to develop reliable and relevant real-world outcome criteria for older adults. So I applaud all the efforts that you guys are doing here in that, and I anxiously await your findings. Knowledge gaps. We need to establish the validity of self-report and objective measures of functioning, and I know that you guys are actually working on that right now. How well are older adults able to rate their own physical, emotional, and independent functioning? Identify the best predictors of real-world functioning. There's significant variability in environmental demands and support, so that requires very sensitive instruments to be able to predict that, and we have to recognize that predictions may be outcome-specific. And then using the above to identify targeted interventions to improve real-world functioning. And with that, I just want to acknowledge my lab, my current students, Shannon Gelb, who just graduated a few weeks ago, actually. I got to remove her from my slide, but that makes me kind of sad. Theonia Peterson, Jessica Kubik, Sophie Young, Ashley Fisher, and Alicia Coolin all worked on these projects. And Ann Shirk and Michael Smith Health Research Foundation for funding this. So thank you very much, and I'd be happy to entertain your questions. Yes.
So when you're talking about everyday problem solving, you're saying it's accounting for a lot of variance. Are you speaking more about the well-structured or the ill-structured, or does it not matter? Do both seem to?
I'm assuming it doesn't matter. And I'm assuming it doesn't matter. When we did our meta-analysis, we looked to see if there were reliable differences across studies, and the effect sizes were virtually identical. So we actually combined them in the meta-analysis. In our own lab, with older adults, I have just to date used the ill-structured tasks, but with the schizophrenia spectrum disorder samples, we're using both, and they both seem to be performing equivalently. So we're now going to start using both in the older adults. The problem, and I know we've talked about this a little bit with the ill-structured tasks, is they take so long to give. I've been trying to get rid of them. So if any of you are Marine students in here and you start seeing these appear in your lab, you have me to thank. They're hard to score. So I keep telling myself we're going to move to the well-structured tasks. We're going to make the plunge. But I believe that there are somewhat different cognitive correlates, underlying them. So I'm just, it's hard for me. I think right now we're still using both. Well, we will be using both for older adults in this next series of studies. Yes?
The serum tests that you guys did, and I don't know the intricacies of drugs, I suppose, in this, but is there any way to maybe make, I know when they want people to check their diabetes, there's this little, you put your finger on it and it gives it a little bit of blood and it checks for
Right.
sugar levels. Is there any way of utilizing some kind of technology similar to that to at least check one drug, see if one drug's
Not that I'm aware of. Not that I'm aware of. So, this has to be sent out to an outside laboratory. So at least they give the impression that it's hard to do. Right? Oh, sorry, yes? Okay.
For the pills, have you guys tried using weight at all? So you could say, you can tell when pills are being removed?
What they actually took them out.
I was very interested to see the pressure plates that you guys have in the smart homes. Is that what you're talking about?
Well, I was talking to someone in your public about this.
Okay.
About like the different, like how much pills weigh, and maybe like taking like a gelatin capsule and taking like all their morning pills and putting it into one big thing so it's heavy enough that you could pick up the actual packet of pills that they should take in the morning, and so you could get data of, you know, this much weight was gone. You still wouldn't know if they ingested it. You still wouldn't. But the mere fact that they would take one out every morning, the chances that take a lot of effort to fake the results.
Well, you know, it's because I mean we're just starting a new adherence study, so I welcome any input that you guys have on this. I don't like just relying on self-report, and I am eager to be convinced that there's a better way to do this. I don't think the men's caps is the way to go, and I like the sort of multi-method, you know, way of sort of trying to combine. But even the other methods that we had weren't really useful. So something like that would be, so we'd have them put them, so instead of using like a pill box, we'd have them actually have to sort of wrap them up. So it would take an awful lot of effort.
Well, like group health pays somebody to come to like all those people for like an hour a week and put their pills into the individual thing.
Right.
Because it costs that much to them.
Right.
And so they're already spending a lot of money that
Right, I see what you're saying.
flushing out toward, and especially somewhere in Canada where you have it all together, where, you know, here Walmart doesn't really care for the pills.
Right, whereas when you're in a socialized medicine system, they really want you to take your medication and be healthy. Well, I mean, you know, again, those are interesting ideas, and I welcome dialogue on that, absolutely. Hang on, I think you had a question here? Okay.
Well, I wanted just to let you know that about half your audience is from speech-language pathology, not ecology.
Okay.
And I had them come because they're neuroanatomy, and we have a lot to do with neurology, and it's great to hear from other disciplines what's going on. So
Oh, good.
Our students getting to join today. I had one question regarding what have you found are the big things that have mimicked dementia? I mean, you mentioned like there's certain health issues like
Mimic dementia.
Or at least like make people exactly. Depression's a biggie. You know, others.
I mean, you know what? I mean, one of the things, you know, when I was working clinically, I mean, I can't tell you how many referrals I had for quote depression versus dementia, and oftentimes they coexist. Polypharmacy is a huge problem. Again, when I was working in geriatric psychiatry, you know, the first thing that would happen was we would do a pharmacy review. And it was amazing to me how many of those drugs were immediately peeled off and how many dementias were miraculously cured. I see, you shouldn't even get me on this because I got to rave. I can feel myself going with this.
well, I think it's a great topic.
Delirium. This is a case, I actually published this case because it blew my mind, okay? In an inpatient woman who was diagnosed with mild dementia, saw her, we were going to release her to home. She crashed cognitively. And we were sitting around the multidisciplinary team trying to wrap our heads around what could cause anybody to crash in 4 months. Must be frontotemporal dementia, maybe a PICS. I mean, it's just crazy. She just completely crashed. We were going to release her to a nursing home until they discovered that she had a chronic urinary tract infection. I'd never, you know, I mean, I'd read about this, but when you really see it in front of you, it's astonishing. She was treated for her chronic and very medication-resistant urinary tract infection, and she was miraculously cured and released to home. You know, I mean, the thing about working with older adults is that these systems are their systems are fragile, and so you know, I really value the time I spent working in geriatrics because, you know, you can see how tenuous their cognitive status is. And the variability in day-to-day functioning. Somebody can be fine in the morning and crash in the afternoon. We call that sundowning, which I'm sure that you're familiar with. And something as simple as a medication change, adding another medication, a urinary tract infection, a grief reaction, you know, or depression, So many of these things can really suppress their cognitive functioning. And so I'm always very, very cautious. I mean, I think, and it sounds, I think we can't have enough respect for the voice that we have in placement decisions, okay, about where this person ends up going. And recognizing, once we really wrap our heads around how fragile and variable their cognitive status is, we need to take that very, very seriously, because, you can make some really bad decisions. Yes?
So I have actually worked in pharmaceuticals. I worked in pharmacy for a really long time.
Okay.
And I was wondering, you were talking about using MEMS caps, and I believe he was discussing bubble packing,
right,
and other long-term care options like that. And I was wondering if the way you control how the subjects are taking their medications impacts at all that problem-solving type influence, because we had a lot of people come in and they got their pills in a bottle. We had a lot of people come in that their insurance paid for bubble packing,
right,
and those seem like problem-solving tools in of themselves. So how does that affect or skew when you're developing?
That's a really good point. Thank you, because of course that's. When we bubble pack, when we put it in a pill dispenser, what we are doing is enhancing environmental support, right? And to the extent that we enhance environmental support, you're absolutely right. We take the problem-solving component out of it, much of it. So then, that's a different research question in a sense, right? But it's a very important research question. And I know, from some of the stuff that I've been talking to Maureen about the last couple of days is, it's amazing how much trouble older adults have, as you shared with me, just getting the getting the medication into those pill boxes, right? So, we can give somebody a pill box, but they still have to go through the problem-solving task of using it. Sometimes, the reason one of the reasons I think that we see better adherence with increasing age, okay, older adults have better medication adherence than younger adults, is because they have more environmental support. They have a spouse nagging at them. Did you take your medications today? The doctor said you need to take your medications. Or actually physically giving them the medications, or putting it in the pill box for them, right? Whereas, the younger adult, it may be personality factors where they just don't take the illness quite as seriously. Or the moon face that they get, is so disruptive that they're just, some of the side effects from these very powerful anti-rejection drugs that they're just not willing to tolerate. So you're absolutely right. As soon as we intervene, we absolutely change the process, and we change the cognitive correlates of the process, right? And that's going to affect our predictions tremendously. Any other questions?
My students I don't think are really smart. How so it's just asking.
Oh, yeah. They're doing something really cool. Yeah, it's amazing. So Maureen should talk about that.
Yeah,
I won't do it justice.
What we're trying to do is find ways to keep older adults and people with physical and cognitive disabilities longer. And so with the help of the engineering students who do all the hard work in terms of making the smart home work, we are bringing people into the smart home. We are having them do lots of different activities in daily living. We are comparing that data with how they do in the laboratory with questionnaire type measures. We are taking some of this technology into people's homes. We are looking to see whether we can use the technology to actually monitor different activities that people do in their everyday lives, and then be able to understand and kind of learn about the patterns that people have, so we could detect, for example, if someone didn't get out of bed in the morning and then go make breakfast, and then be able to alert someone that they need to be checked in on. We're also looking at queuing technologies to help people initiate things like if they forget to take their medication, or if they want to start an exercise program, for example, and they don't initiate that exercise within a certain time of day that they said that they would do it. Some of the things that are really exciting about the smart environment technology is that it actually can be more context dependent. So you don't have to remind someone to do something when they're sleeping. You know when they've gotten up and they're moving around, and that's a good time to go ahead and give them a reminder. We're also ultimately hoping to be able to figure out ways to know when someone is having difficulty in the middle of a task and then actually be able to cue them to get back on track and to finish the task. And in our smart home, we are working with that more with experimenter-controlled cues. But ultimately, we'd like to automate it, and we have a number of students in engineering and computer science working on that very, very difficult question. And we were trying to get as much information as we can just from the sensor data, and very interested if we can use that information from the sensor data to also predict functional health and functional status too. So how well can we relate that to our behavioral measures and to our measures that we take in the laboratory, so that we could actually know if someone is starting to show decline, maybe because of health-related reasons or cognitive changes, or maybe there's just a change in their medication and it looks like their everyday pattern has gotten disrupted, and so maybe we need to go and intervene. Anyone else want to add anything?
It's a series of motion sensors. So you have to get this idea that there's like motion sensors in the ceiling, and there's door sensors in the doors to see when the door opens and closes, which doesn't necessarily tell you when you leave. There's temperature sensors in the rooms, which is doing something kind of different. I think it's going to work on more on like changing preferences and
Energy expenditure.
yeah. I know there's like some electronic sensors that sense when things are turned on, when things are turned off. And so it's kind of like, well, the sensors say there's a person in the bedroom. What are they doing there? So it's kind of trying to figure out what they're doing, and then trying to figure out if we can prompt them to do other things. Like, oh, this person is now doing something in the bedroom, and they weren't for a long time, so they probably woke up. And then these sensors went off, it looks like they went into the kitchen, and we know that they like to take their medication in the morning. So since they seem to be in the kitchen making breakfast, maybe we should remind them that they should take their medication. That sort of thing. And when she says item sensors, it's, what we have right now is we put the pill box on this weighted sensor, so it can tell that the pill box is on the sensor, and then when the pill box comes off the sensor, then you can tell that it's been removed and hopefully been taken removed.
I think one of the exciting things about this area is that it really is multidisciplinary. You need computer scientists, you need engineers, you need health-related people, so it's really exciting and also challenging to work together in groups coming from different disciplines, looking at things from different directions, but it really leads to just so much stuff that you can do. So we're having a lot of fun with it too.
So when you're saying something's cueing, is it an automated voice? Or?
At this point, yes.
Yeah, yes. Believe it or not, what we did was we came up with 8 different tasks. We broke those tasks into steps, complete the task, and then we came up with an indirect cue, which just kind of orients the person back on task. So say they wander away when they're cooking oatmeal. Could say something like, oh, that oatmeal looks good, to kind of get them back on task. Then we go to a direct cue. You need to be stirring the oatmeal. And then we actually have a multimodal cue where they're directed to go to a computer screen, and then they're given, they're actually see what they're supposed to do while the verbal direct cue is given. And that took a lot to design all those cues and then to program all those and get them in there. And right now, all of what we're doing is experimenter driven in the test bed with those cues. So the experimenter sits up there. When the person starts to have difficulty and they feel like they need a cue, they initiate the cue.
There you go.
But the voice of our cues is is a graduate student, has a very pleasant voice. Yes, because when we do the in-home cueing, we always ask people, well, who would you like? What kind of voice would you like? Do you want an automated voice? Would you, want someone you know? And they all just want a pleasant voice is usually what the answer that we get. Just a pleasant voice.
We were talking about that at lunch, though, and I think it's just really challenging because you think about, the hearing problems.
Yes.
Yeah.
And a certain sort of, is it decibels? Am I thinking about that properly? That they can't really hear and comprehend very well?
So I'm just thinking, my question is it for a sound field, or would it be geared to like a digital hearing aid? So like hear it in their areas.
Yeah, well, and that's one of the first things. Every time you guys go in, I say, make sure they can hear the cues. That's their, like, their biggest job, is to make sure. And we have to figure that out, too, depending on how big the household, what's the best system to put in for them to be able to hear the cues. And you're right, there are certain frequencies of hearing loss with aging, and so we do need to pay attention to that, too. So there's lots of and that's one of the reasons we're teaching this geron technology class, that we've got students from engineering and computer science and aging, and we're learning about general gerontology and age-related changes as well as technology, because you have to understand those issues when you're designing for the aging population.
Well, and even something as simple as making sure that the syntax of the cues can truly be comprehended by an older adult who may have dementia. Mm-hmm. So you can't have a lot of fancy language in there that's ultimately going to turn it into a working memory type task, right?
Which some of our cues are a bit lengthy.
Right. Yeah. And so they may not even make it to the end of the cue, right, if they don't have sufficient working memory. So, Susan Kemper wrote an interesting paper on, elder speak, what works and what doesn't, right? And the notion there was older adults hate to be talked down to in elder speak. They can't stand it. The kicker is it actually facilitates the comprehension. So if you use elder speak and you use exaggerated prosody, which nobody likes to be talked to like this, because it's extremely annoying, but you have very short sentences, older adults will learn better, even though they hate it. So that's the elder communication predicament model, right? So even though they may not like it, is there a way that you can capture what works about elder speak to actually facilitate communication? So. Of course, they'll all run out of your smart home screaming at a certain point.
So far, even our individuals with minor cognitive impairment are responding really well to indirect cues.
Okay.
It's been very, very positive. And anecdotally, they report that they prefer those better than being told exactly what to do.
Yes.
But the Alzheimer's patients still have difficulty even with the multimodal cues. But at this point, we haven't done a lot of pre-training. It's just kind of like they come in, we tell them what's going to happen, and then it happens. We haven't sat down and kind of trained them in use of the system. So that's a question, that's a future question down the line.
Right.
Well, we're not the only ones with a smart home. Florida has one, Georgia Tech has one, and they have different interfaces than we do. Mm-hmm. The Gator Home in Florida has a robot, about maybe 2 feet high, follows them around and tells them what to do. So it's a little, it's weird because I don't think there's been a whole lot of research done on which one works best and what would work best for the older people in home. So there's lots of things going on. The vocal cues aren't the only things that are out there right now.
Well, before we get a stronger cue, Dr. Thornton is going to be in room 130 here in this building for the next about 4 to 5. If you'd like to continue talking a little bit more, do, but let's thank our speaker.
I want to